and I am a social worker and team member of the Geriatric Echo. I want to take this opportunity to thank our sponsorship. This CME activity is jointly provided by the Queens Medical Center and the University of Hawaii Jasmine Department of Geriatric Medicine. Joining me this afternoon is our interdisciplinary geriatric echo team. We are all willing to teach and share our collective experience and wisdom with you. Please welcome our advanced practice nurse, Courtney Nunokawa, pharmacist, Dr. Chad Kawakami, psychologist, Dr. Lucas Morgan, and our very own geriatrician, Dr. Rita Bell Fernandez. Just as a reminder, there are evaluations that are required if you want to receive your CMEs. You can find the evaluations by following the link in the chat or at any time on our website and email advertisement. Your comments are very important to us and is useful to the planning committee for future programs. With regards to ECHO, we want to emphasize that this ECHO webinar serves as a forum for mutual teaching and learning from experts and from each of us on the front line. As our ECHO motto goes, all teach, all learn. So it will take all of us to create a community of learning. Our ECHO webinar format includes a short lecture from our expert presenter, then followed by open comments from the expertise of the ECHO Hub team. Our attendees' comments, questions, and examples of case discussions follow. And additionally, we also invite you to share any geriatric cases. Lastly, we ask that you please keep case discussions HIPAA compliant. This includes not sharing patient's name, birthday, address, and so on. We learn best from our patients and our clients. They are our best teachers. This afternoon, I'm very delighted to be able to introduce to you our guest speaker, Chad Kawakami. Dr. Kawakami is from the island of Oahu. He graduated from Oregon State University with his PharmD degree. Thereafter, Dr. Kawakami completed a PG1 residency with the Queens Medical Center. After residency, he worked as a clinical pharmacist at the Queens Medical Center, Tripler Army Medical Center, and the Department of Veterans Affairs, Pacific Islands Healthcare System. Dr. Kawakami is also a lieutenant colonel in the United States Army Reserve with more than 16 years of service. He presently is commander of headquarters and the headquarters detachment for the 1984th United States Army Hospital Pacific. Thank you and welcome, Dr. Kawakami.
Hey, Sarah, thanks so much for that introduction. I see a hand up, and so I wanted to, Dr. Saltman.
Thank you, Chad. I just wanted to introduce myself. I'm Dr. Saltman. Dr. Fernandez asked me to participate today to offer a primary care internist perspective, which I'm happy to do. And I'm a longtime aficionado or fan of ECHO programs. So I want to encourage everyone to build a community of learning, like Sarah was mentioning. Feel free to turn on your cameras, to introduce yourself in the chat, or to rename yourself with your affiliations and introduce yourself in the title of your Zoom window. And that'll encourage, it's consistent. You feel free to eat lunch. I'm eating my lunch. That's consistent with the ECHO model and supports the idea that people will get to know each other. We'll build a community of practice that way. Thank you.
Thank you, Dr. Saltman.
All right, thank you so much. Hey, thanks everybody for taking time out of the day to listen to the presentation. I'm going to start my sharing of the screen right now. So as I transition. Right, that's not the good share, sorry. All right, there we go. Good video, good audio. All right, awesome. All right, so hey, thanks everybody again. So today we're gonna bring forth some of the 4Ms concepts, right? But this time we're gonna look at it through medication management. We're gonna focus on that medication, that M, as a component of the 4Ms. Just real briefly, the 4Ms are what matters, right? So what matters to our patients? Other ones are medications, mentation, and mobility. So one of the goals today is to understand and how to avoid making sure that the medications that we recommend, the medications that we prescribe, do no harm and definitely does not affect patients' mentation or their ability to move, i.e. causing movement disorder, or maybe even causing drowsiness, dizziness that leads to falls, hip fractures, and injury, ultimately impacting their mobility. So let's think about how we can put the 4Ms into practice. Again, focusing on medications. Well, the first way to understand, or the beginning, is to obtain some questions, like ask some questions. Obtain the 4Ms through questioning and discussing with your patient. So here's some questions that you can ask that can focus on getting after what medications are important to your patient. So what medications do you currently take? What is the name of the medication? What is the dose? What time of the day? What medications do you buy in the drugstore, the pharmacy, or online? That can kind of help give you an idea of what over-the-counter medications or even herbal supplements your patient might be taking. Do you ever forget to take a medication? And if you do so, what do you do? That can kind of give you a hint on what their medication compliance is like. Are there any of your medications that you think have bad effects for you? And sometimes I even ask them, which is your favorite med and which one is your least favorite medication and why? And that kind of gives them gives you some ideas of what might be important to your patient. A lot of times the patient might say, my least favorite medication is warfarin. Okay, well, why is warfarin least favorite to you? Well, because I'm really tired about having to watch what I eat, maintaining a steady diet or an even diet of green leafy vegetables. And I'm not particularly fond of, frequent blood tests. And so that kind of gives you an idea of a potential intervention that we can make to help make our patients' lives a little bit better. So one of the principles of medications within the 4Ms age-friendly framework is, number one, we have to think of it like this: if a medication is necessary. So, and I like to even start with that underlying if. Sometimes medications, while in a younger patient, may be necessary. There are many cases that in our elderly population that the medication may not necessarily be indicated anymore. And things to think about include time to benefit, life expectancy, the potential for polypharmacy and drug interactions, or even inappropriate medications. Those factors may make a medication that could possibly make a medication not recommended. But if a medication is necessary, we need to consider using age-friendly medications that does not interfere with what matters to your older adult, does not impair mobility, or affect mentation across settings of care. And so a list of medications that may be potentially inappropriate, we could find them on our handy dandy the Beers list. It was recently updated. It's probably due for another update in the coming years, but I believe the most recent is I'm drawing a blank when it was last updated. It was recently updated, maybe like three years ago, I want to say. But it is due for an update. But again, we use the Beers criteria to perhaps surface some potentially inappropriate medications, and that those medications can interfere with your other M's. So how can we incorporate the framework or this idea of medications doing no harm? How can we incorporate that into the plan, the care plan? Well, number one is we need to be able to identify, to review and identify high-risk medication use, document it, and let's take a closer look and see if that medication is still appropriate. If that medication may or may not be appropriate, we may want to consider deprescribing. Maybe there is a dose adjustment that is needed, especially if it's a high-risk medication. Or we may want to avoid their use in general wherever possible. So, a lot of times people ask me, what is the difference between discontinuing a med and deprescribing? Well, discontinuing a med, I think that it's all in the philosophy, right? So discontinuing a med implies like you're going to stop the med and you're going to move forward. So like, I'm going to stop the proton pump inhibitor and we're moving forward and we're going to kind of like fire and forget. But the act of deprescribing is a systematic way of stopping a medication, whether it be discontinuing it or tapering it, but it's a systematic way to stop a med, but also monitoring for the potential recurrence of that particular disease state, worsening of the disease state, or medication withdrawal effects. So it's like landing a plane very gently, right? So we're going to monitor the process as we stop that medication, making sure that the condition for which was originally prescribed doesn't get worse or doesn't get worse. So this is definitely not an all-exhausting list, but these are some medications that we really should screen for regularly in our elderly patient. Now, again, it's not an exhaustive list, but what medications should you screen for regularly? Well, of course, the answer is going to be anytime you have like all of the above, it usually is all of the above, right? So the answer to this is going to be, yeah, it's going to be all of the above. We really need to watch out for benzos, opiates, medications that are highly anticholinergic. Our highly anticholinergic meds, our poster child is going to be diphenhydramine, and other first generation antihistamines such as chlorpheniramine, muscle relaxants like cyclobenzaprine, Soma, even baclofen, tricyclic antidepressants like amitriptyline or nortriptyline, and our antipsychotics. All of these medications can harm our elderly and should be screened for regularly. So the question is, well, what if they are already on these medications? What do we do? Well, if the older adult takes one or more of these medications, as a pharmacist, I am going to discuss the concerns and try to figure out what some of the concerns the patient may have, if they are experiencing any adverse effects. And if they are experiencing adverse effects, or perhaps that we feel that the medication may no longer be needed, that might trigger a discussion with the prescribing physician, the prescriber, and seeing like, hey doc, patient X has been on pantoprazole for many years. Their GERD symptoms seem to have resided. They haven't had any issues for many, many years. Can we consider stopping this medication? The answer may be yes or no, but at least we can have a conversation about whether that medication is still needed or not. So for some of us who are in hospital care settings, so I'm going to talk about how can we incorporate this idea of monitoring medications into different care settings. So for those of us who practice in the hospital, it's important to note that these medications, both individually and in combination with other medications, drug interactions, can interfere with what matters, mentation, and the safe mobility of older adults because they can increase the risk for confusion, dizziness, delirium, and ultimately falls. So we can deprescribe or recommend deprescribing. And again, the deprescribing process includes both dose reductions and medication discontinuation. Again, deprescribing is a positive, patient-centered approach that requires informed patient consent, shared decision-making, close monitoring, and compassionate support. So again, it's a systematic process rather than, and that differs from, say, just stopping a medication abruptly, kind of setting it and forgetting it. Upon discharge from the hospital, we cannot assume that all of our medications should be sustained. So, you get all the patient med list. When they come into the hospital, you start all of the medications. You cannot just assume that once you discharge the patient that all of the medications should be sustained. Remove medications that the older adult can stop taking. So again, make sure we have that review process before the patient is discharged from the hospital. Another tip is, working with the floor, working with some of the nursing staff to include a medication list printout and including that as part of the normal standard discharge process. Discuss with the older adult, their family, or their caregiver what the medications are for, especially if they're new medications. What it's for, how to take them, why are you taking them, what to monitor for, and maybe even discuss how long you foresee the patient being on that medication. There's many times I see a patient who comes to the pharmacy after having maybe a stroke, and they're prescribed aspirin and Plavix and clopidogrel, and they really don't know why they're on those blood thinning medications. And so, we'll fill in the gaps there, but if we don't counsel them, the patient may be on a medication for some reason that they don't really know. And that might be the first steps in non-compliance, because some of them, if I don't know the medication, heck, I'm not going to pick it up. Why is it important? It's not important to me. But having them understand why the medication is what it's for and what it's doing for them can help make sure that they take their medications more routinely. Another thing is we can consult pharmacy. You can ask the pharmacist. We can definitely help in the process. And the key players in medications is going to be your pharmacist or your physician and your patient. In the primary care setting, things to do in the primary care setting. So consider a medication review and a medication risk assessment. Ask the patient, what are you on? Get a good updated medication list. Be sure to include over-the-counter medications, and we do this at least annually. I like to just have a patient do a brown bag biopsy. Just bring all the medications in, clean out their cabinet, and bring all their medications in, and let's sort through them. I can appreciate that doctors and physicians don't have this kind of time to do that kind of deep dive. If you have a pharmacist that can help you, that's a perfect person to engage. And maybe your nursing and your support staff might be able to help conduct the medication review if a pharmacist is not available. Engage the older adult and the family member or other caregivers in providing all medications, including over-the-counter medications for review. So, if you can't get the information from the patient, engaging the caregivers or the family may be helpful. And a lot of times Medicare beneficiaries may be eligible for an annual comprehensive medication review, so it should be covered. And the medication reconciliation is part of the Medicare annual wellness visit. And so that's an important step in identifying potential high-risk medications. So here's an example of a patient, Ms. Moira Rose. She's a 74-year-old female. She comes to the clinic with her husband, and she's transferring to her nursing care. She says that she has low back pain. She has multiple falls at home, and she's often confused. Per Ms. Rose, she's had chronic back pain for several years. In the lumbar region, she has pain that radiates down the back of both her legs to the knees. The pain is constant, severe, can be described as aching and occasional burning sensation to the area. Her confusion affects her ADLs. Upon review of her medications, we find that she's taking ibuprofen 2 to 3 times a day for pain. She's also prescribed an opiate, oxycodone CR20, OxyContin 20, twice a day. She's also on some muscle relaxant, cyclobenzaprine, carisoprodol, and she also takes Tylenol PM over the counter. She can't sleep at night, so sometimes she takes a little bit of Tylenol PM over the counter just to take that edge off so she can sleep. So in thinking about some of the symptoms and asking some of the symptoms that she's facing, according to the patient, she's lost a little bit of weight over the past year, about 10 pounds. She doesn't have a great appetite. She only eats like a couple of fruit cups for breakfast, if anything. She's really constipated, so she really doesn't feel good. She feels more depressed. She says she has more trouble walking and she needs someone to help her. But she has no issues with incontinence. And per her caregiver, Johnny, he says that, she's definitely more forgetful. She cries a lot. She's very confused. She thinks she's in New York, even though she's in Hawaii. And she has some occasional hallucinations that she thinks that there's crows in her room, and she often talks to them. According to her social history, nothing really doing there. They went from living in a large house in Waikoloa on the Big Island, and now they live in a small studio apartment outside of town. The son and the daughter live with them. They can offer some ADL support. And she has a few friends in the community, and she kind of wanted to join the local women's singing group before all of this happens. But now her friends are supporting her with some errands because she's a little, she can't really do the things that she used to do. Just kind of going over this really quickly. Her vitals are relatively stable. Blood pressure is a little bit low. She does have that pain that pain that kind of radiates, and her get up and go test is not incredibly great. She's having difficulty standing. She uses, she just takes a little bit of more time, and she is a little confused. And her labs are generally within normal limits. And here's her MRI of her spine, that she has a little bit of spinal degenerative changes. So this is a common patient that I see in the diagnosis coming off as chronic low back pain. Okay. So in thinking of how you would go ahead and treat this patient, one of the treatment goals is reduce pain enough to allow for physical rehabilitation or maybe prolong the need for surgery. So where I'm going with this, and I forgot to mention, where I'm going with this is understanding what a potential appropriate treatment might be. So you can imagine that treatment of chronic low back pain that has a bunch of muscle relaxers and opiates, what I'm trying to say is that that's not appropriate. And where I'm going with this is to talk about how we are supposed to treat chronic back pain, and then ultimately landing on what a potential treatment regimen, an age-friendly treatment regimen might look like for this patient. So according to the treatment guidelines for chronic low back pain, it requires multimodal therapy is recommended. PT is going to be recommended. I'm also going to reach out to a friend, Lucas, that might be able to help with psychotherapy, CBT, behavioral therapy, because a lot of our pharmacologic therapy may not necessarily be helping her. It clearly isn't helping her right now. And some of the treatment options may not be all that great for her either. Interventional therapies should also be considered if possible. So here's a lot of how we should really be getting after chronic low back pain. Number one, it should be non-pharmacologic treatment. So physical therapy, our psychologists will have key roles in helping to prevent and treat chronic low back pain. If you look at the pharmacologic treatment options, first line is Tylenol. Second line may be NSAIDs, although I don't think that that's a great option for these patients. And as we go down, third line options like opiates may not necessarily be appropriate because of the fact that it can cause constipation and delirium, like we're seeing. So a lot of the medications that we have for chronic low back pain may not necessarily be all that appropriate for this patient. And so in thinking of how we're going to treat this patient, what is the best medications, age-friendly medications, we really need to think about some patient-related factors that we need to think about. So some comorbidities. We want to make sure that the medications that we are prescribing or recommend do not negatively affect their kidneys, their liver, the heart, or even their cognitive function. We want to make sure that they're able to adhere to the medications. We also want to make sure that there's no physical limitations, take their financial status into consideration, and even thinking about some of the new pharmacogenetics that is beginning to surface as we can kind of give custom tailored medications to your genetic makeup. And then thinking about and some of the things that the pharmacists and the providers think about in terms of selecting the right medication, we need to think about the pharmacology, how the drug works, the pharmacokinetics, how the drug works within the body, adverse effects, potential drug interactions, the cost, and the availability of appropriate dosage forms for this patient. So what do we need to do? Well, I think that this patient is on a bunch of medications that are high risk and is not appropriate. So therefore, a intervention is to consider deprescribing and or avoiding some of these high-risk medications. We should specifically avoid or deprescribe some of the medications listed below. And on that patient, we should be considering deprescribing the opiates and some of their muscle relaxants. So if the older adult takes one or more of these medications, again, discuss the concerns that the patient may have, assess for adverse effects, and discuss deprescribing with the older adult. So basically, if we just go back, I'm going to go back here to the medication list. This is an incredibly not age friendly. For one, ibuprofen would be bad because she's elderly, and that ibuprofen at that dose can negatively affect their renal function and can also increase their risk for a GI bleed. Oxycodone has seemingly causing her some constipation issues. She's already a little drowsy, she's a little delirious, and the oxycodone is certainly contributing. And not to mention the muscle relaxants like cyclobenzaprine and carisoprodol are highly anticholinergic, especially the cyclobenzaprine. Those medications are most certainly affecting her cognition, also worsening constipation. And also the Tylenol PM. Tylenol PM has acetaminophen and our geriatric friend diphenhydramine in there. Diphenhydramine is your sleeper, and that is another incredibly dangerous medication for this patient. So I would recommend significantly discontinuing a lot of the medications and deprescribing virtually all of her medications in order. So getting back to and wrapping up our patient here, what are things that we need to do? So consider deprescribing. So here are some tips to deprescribe or avoid high-risk medications. So these medications that she's on can interfere with what matters. It can affect her mentation and her safe mobility, again, due to increased risk of confusion, delirium, unsteadiness, and falls. Deprescribing, again, includes both dose reduction and medication discontinuation. And so again, we want to make sure that we slowly and systematically take her off these medications. So at this time, these are the resources, and I'll stop for any questions that the audience may have.
Thank you, Chad. I really appreciated how you just reminded us about the importance of the 4 M's when we're looking at medications. And from a social work perspective, one of the biggest challenges that I have to deal with our kupuna is they have to decide whether they're going to use their money to buy food and pay for their housing versus being able to afford medications.
Yes,
What about other
definitely.
people?
Definitely. And I think in this case, I kind of threw in there that she had a house in Waikoloa, and now she lives in a small apartment outside of town. So there most certainly is a potential for to work with social work to make sure that we can recommend medications and treatment options that will fit within their budget.
Mm-hmm.
It's also I can also appreciate that CBT and working with the psychologist, it's not it's not cheap either. And so integrating social work into the decision-making process would be very helpful to help figure out payment options or other support options.
And then just
So,
that adjustment of
Alice
transitioning from a
Lu-
house to an apartment too. Wow.
So Alice Liu is asking in the chat, what would you recommend as a replacement medication for the treatment of the pain? Or what, how would you treat the pain? You recommended sort of
Yes.
prescribing the long list. How would you treat her pain besides CBT?
So besides CBT, I think another option, once we clean up our medications, I would probably recommend some of the non-opiate analgesics or co-analgesics. So an option might be gabapentin. So like Tylenol plus or minus gabapentin might be an option. Diclofenac may be possible. I'd be a little bit concerned about the renal effect of diclofenac.
Another NSAID.
Another NSAID.
Yeah, what about Roxanne's asking about topical? I was going to ask that very same question. What do you think? What kinds of topical treatments do you think would be appropriate for her?
So I think diclofenac topical may be an option. We have to kind of watch because sometimes there is a little bit of systemic absorption, even of topical diclofenac. So while I think it's a safer option, but I think we cannot forget that it can be systemically absorbed. And so we may want to keep an eye on the renal function.
What about lidocaine patches or counter irritants?
Lidocaine patches
like Salonpas.
Yeah, definitely. So lidocaine patches, counter irritants may also be options as well. I guess it depends on how bad it is. So I'm kind of concerned. I'd be a little bit concerned because if you're on oxycodone for the pain, it might be pretty severe. So I think what we really need to do is really get a good assessment of her pain and figure out what's working and what's not working. And slowly taper things down and discontinue. So maybe I might start with the muscle relaxant first. Let's get rid of that and see how she's doing. Maybe that improves her cognition. Maybe that improves her constipation. And if that works, then maybe we have to leave her on the opiate. And we slowly start tapering it down.
Chad, you mentioned a bunch of great stuff, and I have a ton of things to say about this, of course. But I wanted to say a few things about medications. Tapering is kind of an art. It's important to taper the things that you're going to use rather than just discontinue them. You mentioned PPIs, the pantoprazole. Sometimes people have been on them for a long time. Those are more effectively discontinued when tapered. Opioids, of course, are more effectively discontinued when tapered. And but I want to say for a person like this, first I want to say I agree with you completely. Like starting with those muscle relaxants is a good idea. Those have a central acting mechanism that is poorly understood. And so they work as muscle relaxants, but exactly why they do that and how they work and what their effects in the elderly are not really very well understood. And those are good places to start. And they, unless somebody sort of swears by it as this is the only thing that works for me, that's a good place to start. On the other hand, I want to say that opiates have been in the, they were in the public domain for thousands of years. So we know that they're effective for pain killing. And they've only been regulated and controlled for, 100 years. So we should have a perspective on those. And again, it's not about opioid all or nothing. It's about judicious use of some of these medications. And that includes, and then it's important. There's a bunch of really important things that you said. Tylenol PM, like people don't know. They think it's Tylenol. They go to the drugstore, they get Tylenol PM, it says Tylenol, looks like Tylenol. They don't know that it's got diphenhydramine in it as a thing that makes it the PM and that is contraindicated for many elderly patients for a bunch of different reasons. So that thing that you said where it is, and it is time consuming, but I had a regular practice where I said, okay, next visit, go home, bring in everything in your house that has your name on it, you know, put it in a big bag and bring it all in. And then, you know, and then I would just take them out one at a time and sort of sort them by category and kind of, and it's time consuming, but it's so worth it because these folks have, you know, they have 50 bottles with their names on them at home that they really don't know what to do with exactly. And they're sort of there, and then they can be using it in a sort of ad hoc way that's not healthy at all. So I wanted to ask you again, do you think that there's side effects in the elderly from using lidocaine patches? And why are they so highly restricted? Why is it so hard to write a prescription for a lidocaine patch?
I don't necessarily think that it's, I don't think that I think it's actually probably a safer option than the one, you know, some of the systemic treatments that we have. The reason why it's probably so hard to write a prescription is the cost. You know, and especially with the 4% being over the counter, I think it's a cost issue.
Is there's a 4% lidocaine patch available over the counter?
Over the counter.
And is that pretty effective? Do people respond
You
to it?
know, I tried it personally for back pain and it didn't do anything for me. And I'm not sure if that 1% more is going to be a game changer, but it didn't really do a whole lot for me. I prefer the Salonpas.
Mm,
And Renata brings up, so I used to
Yeah.
say to people, Renata brings up an excellent point, acupuncture, massage. You know, I used to say to people, well, it's either surgical or it's not surgical. And if it's not surgical, it's the world of non-surgical treatments. And so it can be pharmacologic or non-pharmacologic. And if it's non-pharmacologic, it's a universe of non-pharmacologic treatments. You know, so that's acupuncture and massage and physical therapies. And physical therapies of, you know, in the broadest sense of the term, heat and cold is a physical therapy. You know, they have those sort of massage guns that people can get that sort of they can give self-massage that way.
And in looking at Renata's chat, a couple of things. Yeah, definitely. One of her comments was treating constipation may help alleviate discomfort. Miralax is fairly inert. So I love Miralax. I think that's a great option. And yeah, certainly treating constipation, which she is constipated, affects like the way her cognition certainly and the perception of pain. So I think that relieving constipation is a great place to start. And she also mentioned that I think the OTC lidocaine patches need to be changed every 4 to 6 hours to be effective. That is correct. And you can't wear the lidocaine patch like all day and just kind of rotate it all day. You need some off time as you get that tachyphylaxis. So you can't just keep it on basically. And there's also, yes, there's also the prescription strength 5% lidocaine gel. Over the counter as a hemorrhoid med. You can use that as well. I've used the 5% lidocaine gel. It is a little bit more messy. I've kind of, I think I've worked with another nurse who kind of smartly made their own lidocaine patch with like some Tegaderm and some 5% lidocaine gel. I thought that was rather creative. And also Sarah mentioned keep her moving, gentle yoga, Tai Chi, etc. Yes, to strengthen those muscles. You know, the stability muscles, definitely keep her moving. So I do think that, again, like the best part about this case is that, you know, medications is just a small part. And when you use medications as the only part, I think then that's how you end up with a patient on those types of medications. So multimodal pain medication, multimodal approach would most likely be helpful.
Is there a case today? Does somebody have a case to discuss?
Dr. Salmon, usually at this point, we open it to everybody who might have a case or additional comments about Chad's presentation.
I wanted to be mindful of the time, but that's a really good case, Chad, and it's really, there's a lot to say, teaching points about it, I think. Other comments? You feel free to unmute your microphone and oh yeah, Courtney's asking a question. I had that same question. Curious about the clinical application of pharmacogenomics. So my question is there a blood test you can do to see what kind of metabolizers people are? Like, are they fast metabolizers, slow metabolizers? Is there a way you can sort of get at that in a clinical way to avoid dose stacking and kind of that sort of problem of overdosing or underdosing with say a medicine like duloxetine, for instance, you mentioned as a pain medication, right? That's a good one to know about the metabolism of.
Yes, I think there's a lot of new research about pharmacogenomics, rapid metabolizers and slow metabolizers. I think the part that is most common in practice that I utilize most often is the 2C19 test. And that one is geared towards clopidogrel. So clopidogrel, otherwise known as Plavix, is a blood thinning medication we commonly use after stroke. It's a very or in heart attack too. And it's a very important medication to prevent future strokes and future blood clots. Clopidogrel is metabolized to 2C19 to its active form. And if you have a genetic polymorphism within that 2C19, I guess that enzyme, you don't make it, then basically you don't convert your drug to the active form. And so what happens is it doesn't work for you. It's virtually useless. So we do test, and if we find that you are a slow metabolizer, then we pick something else. So that's a clinical application. There's also some potential pharmacogenomic testing that is looking at potential responses to certain antidepressants. I don't think that we use that in practice, at least not that I'm aware of. But I think that there's some interest in getting genomic sequencing and then tying that to drug profiles and saying like, okay, based upon your genetics, these are some potential antidepressants that you might be more likely to respond to. So for any of us that do mental health, picking an initial antidepressant is kind of like a shot in the dark, right? You just start something and hope that it works. And hopefully in the future, we can do some pharmacogenomic testing. And then that gives you a panel and says, okay, of all of the antidepressants, like I think duloxetine, sertraline, and, I don't know, amitriptyline, for example, are your top 3 best bets for getting an effect. And you just pick from there.
I've always been impressed by those big studies that look at antidepressant medication that really doesn't seem to show that any one of them is any better than any other one. And it really is just sort of hit and miss, trial and error. And that the studies don't guide you towards an answer particularly.
No, it doesn't. And so that's where there was interest in the pharmacogenomic testing to help you. So one person mentioned it, and I think that it hits the nail on the head. So pharmacogenomic testing, instead of like throwing a dart in the dark, trying to hit a dartboard in the dark, it's like just turning on the lights. You still might not hit the dartboard, but at least you know what you're shooting at. It improves your chances of success.
Well, is in that light, I mean, let's say you're you have a specific patient on a specific sort of therapeutic pathway with therapeutic goals. Can you draw a level of the medicine? I know that this is kind of outside of the usual practice, but could you draw, a sertraline level and sort of, an hour after the dose and see whether it's effective or not? Is that something people do?
No, not necessarily. No, I think you probably could do it, and they probably do it in the early phase 1, phase 2 studies just to kind of get a feel for what the appropriate dose is. But getting a level. I mean, even if you had a commercially available level, there's really no clinical study that say like this is the range that you should be in. Kind of like your vancomycin or some of your other medications. So long story short, there really isn't a level that we can really monitor and tie to any efficacy.
Okay, good. The questions are coming in. Courtney's asking a bunch of great questions. So medication selection within a class, that's a good question. Is there, so in your, so you
Yeah,
said
is it like, oh,
say
sorry.
again?
I was thinking like, is it SSRI versus SNRI, or is it really refining even within an SSRI class what to?
I think even within an SSRI class. So just kind of a fun fact, a lot of our SSRIs, we lump them together as an SSRI, but they're structurally different, sufficiently structurally different. That's why we can say like, if you fail one SSRI, you can recommend another SSRI because they're structurally different enough that like one may work and the other may not. Versus say like the difference between lisinopril and ramipril, like they're essentially very structurally similar.
Yeah,
So
right.
if your ACE inhibitor doesn't work, it'll pretty much knock out the whole class.
It depends on the class, the HMG CoA, the statins, they tend to be pretty similar in a lot of ways. And the ACE inhibitors are similar, but beta blockers tend to be, there's a bunch of different unique things about them, and I don't know.
Yeah.
It depends on the class that you're looking at.
Yeah.
PPIs
So
are pretty similar.
SSRIs are rather hetero. It's like a very different group, even within the class. And then Courtney also mentioned, like, I think Asians are overrepresented with poor Plavix metabolizing, which is a large majority of our GERD population in Hawaii. So yeah, that's why we do a lot of those genomic testing, a decent amount, because Asians tend to be slow metabolizers of Plavix. So that's why we do it. Yeah.
So just for that, you said something about pregabalin didn't work. What was the story about that? In that slide, you said that pregabalin, that's Lyrica, pregabalin. What? It doesn't work?
Oh, you could consider pregabalin. So I was just mentioning that gabapentin. Sorry, let me pull up the slide real quick. Here, I'll just share it as it is here. So gabapentin is good for radicular pain, and it just so happens that pregabalin was shown to be ineffective for radicular pain.
I thought it was metabolized into the same thing.
Not necessarily. So gabapentin is not necessarily metabolized directly to pregabalin, which is an active. Gabapentin is a prodrug, but it's not metabolized directly to pregabalin. Similar, but not directly pregabalin. I can't remember what the active metabolite of gabapentin is though.
So yeah, gabapentin's there's a lot to say about that too. It's a tricky drug to use in my experience. It's a lot of people prescribe it as a kind of 100 milligram as a bedtime dose or something like that, and sometimes patients say that it works, but it's not supposed to work like that. It's it's sort of a 3 times a day drug with escalating dosages and these steps, and it goes up to large doses, 900 milligrams 3 or 4 times a day, which is hard to get to. So unless, in my experience, I rarely use it unless it's clearly neurogenic pain that's not really responding. Neurogenic pain, that's a good place to start, and that you got to commit to the dosing if you really want to see if it's going to work or not. Because if you give them 100 milligrams 3 times a day and it doesn't work, and you go up to 300 milligrams 3 times a day and it still doesn't work, but you're really, your clinical, your pre-test thought on it is that it's a neurogenic origin of the pain, you might want to stick with it and keep prescribing it at higher dosages. And so how about that in the elderly, Chad? Is it, sometimes it makes people sleepy. It takes them a while to get used to it. What do you think about using higher doses of gabapentin in the elderly for neurogenic pain?
I think it's always it's risk versus benefit, in my opinion. So I think we do the go low, go slow. So you start at the 100 milligrams at bedtime, and then you slowly titrate it up to an effective dose, which usually is about 600 milligrams 3 times a day. That's kind of like where I start to see some benefit. You might see some benefit at lower doses, but I'd say across the board, probably about 600 milligrams 3 times a day is where I see benefit. Just being aware that it may cause drowsiness and dizziness. And so that's where understanding the 4Ms and being able to monitor and watch it is going to be important.
So the
So I
other
didn't
thing
really-
I like, oh, go ahead. Lucas, please go ahead.
Yeah, just wanted to jump in and just say I really appreciate all the great discussion going on today. Because there's endless questions involved in medications, not only of course on the chemical level and the physiological level, but in the application of medications in real life. And as a psychologist working with geriatric folks predominantly, it's always apparent how many patients have a very poor understanding of what medications they're taking, like what are the names, let alone sort of the classes. And and I think I appreciate two practical things I heard today about trying to help assess a patient's current level of understanding. And one is Chad's recommendation of bringing a printout of everything, of the list of medications through the visit. So having that piece of paper with you to look at together sounds like it could be a really good strategy. And then Dr. Saltman's practice of asking folks to bring their whole medicine cabinet into the visit sounds like a really potentially useful way to just talk about things and see where patients are at. So I really appreciate those practical strategies, because your medication regimen is only going to be as useful as the patient's understanding of it and then their application of it as prescribed. So I wanted to say, yeah, appreciate those suggestions.
Thank you, Lucas. Absolutely. I just want one other pearl. I'm sorry to chat. I'm chatty Kathy today. One other pearl though is that's in that same vein, and that is, I tend not to ask people if they miss doses of this medicine or that medicine. I ask the question. I say, in 1 week's time, how many times do you skip this medicine? And it's sort of more permissive in the way you ask it. Like they can say 0 if they're perfect about it, or then there's sort of an implicit understanding that nobody's taken all their medicines all the time. Like that's really unusual. So they get to say, oh, it's 1 or 2 times a week, or it's half the times or something like that. So that's a good way to solicit that question, or solicit the information about that problem. In 1 week's time, how many do you miss? Oh, and here there's a bunch of good stuff in the chat too. I'm sorry. Go ahead.
Yeah, definitely. Just want to address some of the great stuff in the chat. Timing of the medications, definitely important. Starting gabapentin before bedtime is an excellent idea, especially because it can cause drowsiness and dizziness. So giving it at bedtime can kind of help you fall asleep and also mitigate some of the risks there as we titrate it up slowly. And then Naomi mentioned, decrease the doses of gabapentin and pregabalin for those with renal insufficiency and renal failure. Yes, so we go slow, we titrate it up slow, and we'll probably use smaller, lower doses. Absolutely. Those drugs are renally cleared and can build up in renal failure. And Roxanne mentioned the favorite, yep, mine too. Patient insists that they are adhering to the medication dosing, yet the last fill was 6 months ago for a 30-day supply. And so she brings up a good point in that another way to kind of get a ballpark is to see what their refill history looks like. I mean, are they refilling it regularly. I think it can be that is definitely useful. And it kind of does give you a some insight. Although I have been kind of burned one time in that the patient was getting automatic refills. So yeah, so I caught that on the medication brown bag when there was like, I don't know, probably like 1,500 tablets of automatic refills.
Hmm.
And then you know, at the VA, they sometimes they don't pay for the medication, so they don't care if they got like 5 years supply. And so anyhow, that's one way to check is looking at refill history.
I just wanted to add about sort of, you know, patients being honest about medications, because a lot of folks I see are kind of scared to go to their physicians or and talk about medicines because they don't want to get in trouble. They don't want to get scolded. And so if a physician or a prescriber has sort of like a parentalism approach of like, you know, don't be naughty, be a good patient and take it, you're probably going to get more false reports, some of which are because of fear of being scolded. And so if our goal is really health, we want to know. And so sort of like Dr. Saltman had, using ways of asking questions that are a little bit less scary and a little bit less sort of accusatory, you know, could be a bit of our language to take a look at sometimes.
I think, Lucas, you bring up a great point. And yeah, using non-judgmental language and posture. Yeah, I agree. Yeah, and that's an echo talk, I think, even in the making. But you know, it's like when the doc asked me, like, Chad, how much alcohol do you drink? My answer is 0 all the time. 0.
Yeah.
Never.
Yeah.
You know, it's even, I got to tell you, it can be even worse than that. Prescribing insulin, you know, there's multiple times I've heard providers sort of use insulin as the threat of doing something. You know, if you don't eat a better diet, you know, I'm going to have to start insulin on you, kind of thing. That's a really poor practice, in my opinion. I think that's offensive, and it's not good medicine. It's not respectful for patients. You know, there's nothing wrong with insulin. It's not a punishment. It's, in fact, it's a reward for like, you know, for somebody who's interested in motivated for treating their diabetes.
Hmm.
But you know, Dr. Saltman, from the patient's perspective, it's one of respect to their physician, and they want to please you. They don't want to disappoint you or any provider. But they'll be-
Absolutely, and that's why you have to be delicate about how you ask questions, because if you're interested in the information, the real information, if you don't ask the question a certain way, you're going to get an answer that doesn't tell you what you want to know. It's going to tell you what they think you want to hear, and it's leaving you, you know, it's leaving you in a place where you're making decisions based on half of the information. It's a, you know, it's a daily problem. It's kind of a routine sort of problem that you got to approach that in a certain way, because some patients can be so respectful that they wouldn't do anything to sort of, you know, to shake anything up in any way.
And even
Oh,
sorry, I was gonna say, even asking about side effects, right? Certain ethnic groups may not necessarily say like, yeah, doc, the medications you gave me is killing me. You know, they're just gonna, despite all the side effects, they're just not gonna say anything. So again, those are kind of creating that safe environment where your patients can tell you what they need to tell you.
so I think we've touched on a lot of the complexities and the sort of the art of prescribing and working with medicines and working with human beings in all their sort of amazing complexity and mystery. So wanted to thank everyone for being here today and for the fantastic talk by Chad and a very interesting discussion and questions. So please check out the evaluation or fill out the evaluation for your CMEs and send us any further questions that you might have. And there's some great ideas for some future talks. I think, you know, Chad, you were mentioning one really good thing before you go is that I just read that Aloha Care now covers hula and lomi lomi. So some further sort of non-pharmacological kind of treatments that we can send our folks to you. So really mahalo everyone for being here, and have a great rest of your days.
Right. Thank you, everybody. Appreciate your time.